That she was so gracious to have someone squeeze her calf, and that test to see for what? If your Achilles tendon is ruptured. Yes. We also talked about compression test. Do we remember compression test? We are compressing a break in what? We did. We talked about this. Yes, we compress the tibia and fibula together, see if we've got a fibular fracture. It's pretty accurate. There was one time that the entire year, 10 games the entire year, I never went on the field for football. First playoff game. Holy smokes. There we are. We're playing over the field in Garland. And it was the fourth quarter even. It was less than half of the fourth quarter was left, probably about 3 minutes left. And lo and behold, somebody is out on the field. So we get there, and I look at him, and he's talking to me about his ankle, and then I did the compression test, and his fibula was actually out of alignment. And when I did it, it actually, you felt it slide back in, and it popped. All right? So he felt better, but yes, I know now that he's got a fracture. So our team doctor was there with us, and he says, it's not fractured. He looked at it after we got him off the sideline. He says, absolutely not. It's not fractured. I said, oh, yeah, it's fractured. He says, no, it's not fractured. Lo and behold, the kid went in on Monday because they didn't have Saturday clinic, or this was a Saturday. And so he went back on Monday, and lo and behold, that test where I told him that it was fractured, it was true. He did fractured his ankle, his fibula, down at his ankle, and he was done then for the playoffs. So we've seen, I know that y'all have seen ankle sprains, right? So you see these ankle sprains, and you got to have an understanding. What's sprained? What is this person going to have a problem with? And to do that, you know what test to do. All right. We haven't done the knee. We're going to do the knee probably next. All right. And there's a test that's called an anterior drawer test of the ankle. There's also an anterior drawer test of the knee. And the anterior drawer test is used to determine the extent of the anterior talofibular ligament. So you've got a hint right there. It's the anterior drawer helping to find out how the anterior ligament is doing. So it's primarily and to the other lateral ligament secondarily. So if the ATF is gone, and then if it really keeps sliding, then you've got more of your calcaneal fibular and your posterior talofib if it really slides out. So it's a pretty easy test. They sit on the edge of the table, and just like so, and I'm going to take your foot and relax your foot, and I'm going to have it in 90 degrees. All right? So in 90 degrees, and especially if you have on really cool socks, it helps a lot better. All right? Don't have them wearing a shoe because the shoe's going to give anyway. And relax your leg. Relax your, yeah. And so you've got to have an idea. That's all I'm doing, is I'm pushing down and pulling up and then doing the opposite. His anterior talofibular ligament is just fine. Now, if I'm doing this and you have a positive test, when you do this, what will happen is you will feel a clunk. The talus will slide out a little bit, and it will clunk on these malleolus. And then as it goes back, it'll clunk again. So you get a clunk. Now, is that absolutely 100 definitive? Not quite. Because what if this athlete has had previous anterior talofibular sprains, and now that ligament is not near as taut as what it used to be? So what we need to do is we also need to check the other side. Pretty much with all your tests, you got to check both. Compression test, no. Thompson test, yes. They might be somebody who is really loose as far as their flexibility, and you might take it as, that movement's not a whole lot. Check the other side. That movement might be the exact same on both sides for that. So you want to do that with your anterior talofibular ligament, with the anterior drawer test. And there's your picture. Now, when you see this, you're going to see this picture again. It's going to ask you either name that test or what ligament is it testing. Might ask both. Talar tilt. Where's our talus? Help me. Having brain block now. Where's our talus? Somewhere down there where you've got that narrowed down. And see, that's the thing is that when we get athletes that come in, and they come in and I say, where are you hurt? And they go, from here, that hurts here. All right? To them, that is really specific because think of it. Not only have I chopped that half off over here and got rid of that foot, but now I can chop all of this off and all of that is gone away. So to them, they're really specific. To us, once we know anatomy, that's not very specific. All right. So our talus sits on this foot without them. There's the lateral malleolus, the medial malleolus. So it's in between them, right there. So how are we going to do a talar tilt? Simple. Put it in. We actually put it at 90 degrees, and we're going to hold here, and we're tilting the talus. Now, what ligament do you think we're actually going to be checking on there? If I'm doing this, the one right there, exactly. So that would be your calcaneal fibular ligament. So with the foot positioned at 90 degrees, and the calcaneus is inverted, check to see if there's excessive motion. Now, once I've looked on this one, I need to look on the other one, and then come back to the injured one again. Get an idea what this range of motion is. Come look at the non-injured, and you've got to make sure you ask them. Now, have you ever heard the other side before? Because they're not going to tell you. There was this guy one time, now I'm going back 100 years ago, when my mother was teaching, and she told me a story of a guy that played football back in the late 50s, I'm thinking. And here's their athletic trainer or their coach, and lo and behold, the coach was out there, the athletic trainer, the doctor, whoever it was at this time, was out on the field, and they were going through, they were checking his leg. They said, does this feel okay? Yeah, that feels all right. Does this feel okay? Yeah, it feels all right. Well, I don't think I can see anything wrong with you. And then the kid finally said, coach, it's my other leg. So, ask questions. All right? The talus, if you've got excessive motion to the injury, calcaneal fibular and probably the anterior and posterior talofibular ligaments are sprained as well. Usually how they happen is you get your anterior talofib, your calcaneal fib will go second, and then your posterior talofib as far as a grade 1, 2, and 3. So the deltoid ligament can also be tested because it's on the medial side. So I'm taking that foot, and not only am I coming in, but I can come out. And there's the deltoid ligament. So that is your talar tilt. Two simple tests. You're done. You're looking at it, and then knowing where they are as far as point tenderness, then you can narrow it down as far as what ligament it is. All right. So you got a grade 1. Now we know about grades. There's grade 2. We got grade 3. All right. Grade 1, 2, and 3. You're certainly going to see grade 1, 2, and 3 on your test. And what are the key words with grade 1, grade 2, and grade 3? Yes, it's mild pain. And not only that, but they're weight bearing. Minimally impaired. That's grade 1, the smallest that you can get. Point tenderness and swelling over the ligament with no joint laxity. And then, how are you going to do this? Put a horseshoe on it. Not like a real horseshoe, but you cut it out of felt. And you wrap it around. You have it come down and around the malleolus. Okay, because if I put just an ace wrap on there, there's going to be a void or a spot that I really can't push down because of how much that bone sticks out. So if I put a horseshoe around it, then I can keep it from swelling up, right? So we want to use price. We want to use a horseshoe to help control your swelling and hemorrhaging. Limit your weight bearing for a day or two. Tape and brace when you return to play, and you need to have them taped for the next 8 weeks at least. All right? So now, what is our job once you've gotten even the mildest of sprains? What is our job then? Well, that's true. We want to make sure that we're going to do some correct therapy on them. All right, but he sprained his ankle last night playing soccer, and they've got another game. It's a grade 1. He's got a grade 1 ankle sprain, but he's ready to play next week because next week is going to be playoff. So this tape right here is going to represent my arms represent a bone. This represents the ligament. Okay, so all day long, here's the calcaneal fibular ligament, calcaneus and the fibula, and all day long, it holds it so that bone can only go so far apart. All right, I get a sprain. Okay, and that's a mild sprain. You got about a third of it torn, but it hasn't translated into the other ligaments. Remember how hard I was pulling it? It doesn't take near as much for it to tear now. So every piece, now this is cloth, all right, which is sort of like your ligament, not made out of cotton. It's just that as you tear tape, we've all seen this when we were first starting to tear. You could get the threads that really see the threads. So if I have this much damage, let's say that that takes 1 week. And then each little piece of thread we tear takes another 6 hours. I've gone through 3 of them now. So there's 18 more hours. Holy smokes, now I'm up to 24 hours. All right? And then there's another 24 hours. Our job is to make sure that we don't add any more time into his rehab. So we got to protect it. I can't say all the time, but I have no problem with going to an athlete and saying, I know you've got a mild ankle sprain. Use these crutches over the weekend. Oh, come on, man, I'm not that bad. I know you're not that bad, but our job now is to make sure that you don't get any worse. Now, you give a grade 1 ankle sprain on a kid who sprained his ankle in the first quarter. We taped it up really good, retaped him at halftime. He played the second half, rushed for over 150 yards, caught 3 touchdown passes on top of that. And holy smokes, what is going on across the hall in the coach's office? What are you doing? There's nothing wrong with him. Why do you have him on crutches? Coach, because we want to win as much as you do. We're trying to protect from having any more damage than what has actually occurred. So even with the grade 1, you can put them on crutches just for the weekend. All right? Now you got grade 2. Uh-oh. Not only do we have that little bit of tearing, we've already torn through that, and now we're tearing part of that next one. So the anterior talofib has already got a good tear, and now our calcaneal fibula is starting to get torn. Not only are we hurting up front, but also down in the middle. Yep. So now we're at moderate. We have moderate pain, moderate disability, and obviously there's point tenderness and there's edema, and you might already start to see the discoloration that happens. That discoloration, do not let it worry you. All right? If that discoloration gets too big, and when it starts to heal, where is that discoloration going to go? Huh? It's going to go towards the toes. You know why? Because that's gravity. It's pulling it. There's no other place for it to go, so it's going to spread out towards the foot. In the foot, gets down the toes. It's got absolutely no other place to go. Now, if you were elevated the entire day, and I don't know of any classrooms that you can actually lay down on the couch and elevate it, probably a couple around here, maybe. That'd be cool, wouldn't it? I think we should. So you're going to get a positive talar tilt. You're also got a positive anterior drawer, although it's not going to be near as bad as a grade 3. So what's our rehab? Crutches, 5 to 10 days. You're going to progress to FWB. What do you think FWB is? Let's think of, let's, huh? Full weight bearing. Exactly. So we're going to progress to full weight bearing. We're going to put you in a protective device. That could be either an ankle brace or it could be a boot. All right? You're going to increase we want to increase our range of motion, increase our proprioception, increase our strength, and decrease our swelling. Do we know what all of those 4 things are? You want it, your range of motion? Proprioception. Exactly. All right. You ever play baseball, softball, maybe soccer, basketball? Somebody throws you the ball. Do you absolutely every time have to look at your hand to make sure it's where the ball's coming? Why? You, really? In the dark. Or close your eyes. Do you absolutely have to find out and reach and feel out where your hand is to know where it is? That's proprioception. All right? But even the smallest loss of your brain knowing where your feet or your knee or your hip or your arm is can cause an injury. And if you're not out there practicing and using your balance, you start to lose it within the next 24 to 48 hours. Anybody ever walk down the street, step on a rock or something, and know they're about to turn their ankle, but instead you just went ahead and fell with it because you knew, if I don't, I'm going to tear up something? Yes, because your body tells your brain, this is as far as my limits are for this joint at this time. That's your proprioception. And you'll lose that if you don't use it. So we're going to do some balance work with them. All right? So grade 3. Here's your key word. What is it? Severe. Severe pain in the region of the lateral malleolus. Not weight bearing is not even possible. There's discoloration. There's positive talar tilt, positive anterior drawer, and when you start doing your anterior drawer, you feel a good clunk, and you'll feel this. All right. So we got to do price. We'll just take that protection and put it in front. So protection, rest, ice, compression, elevation. It's unbelievable how great elevation works on keeping the swelling away. So you increase in, we want to put, what's NWB? Non-weight bearing. Very good. Isometric exercises. Remember last year when we had to look up Charles Atlas? That's the exercises he was talking about, where you're just going to push against something that's not allowing it to move. All right? So increase your range of motion, increase your balance, and you're obviously prone to re-injury. With this injury, you might be out a month. Now, how long does it take for a soft tissue injury, such as muscle, tendon, or ligament, to completely heal? A while, yes. 12 to 16 weeks, 3 to 4 months. Now, does that mean that that athlete is out 3 to 4 months? No. That means, though, that we have to protect them until they were fully healed, for sure. So somebody gets this done, and it's 4 weeks or 4 months later, they are getting taped, etc., for the entire season. Protected. Here's a fella. There's a drawing of an inversion ankle sprain. The one at the bottom is an eversion ankle sprain. Let's see. There's inversion top, eversion bottom, and that one is inversion. So you can get these little things by just rolling it over, straight over. Very easy. Here's the other thing. What about when you get it when your foot's going plantar flexion and then it rolls? High jumper, long jumpers. All right, they land in that box, and whoa, They get just a little bit out, and they land, and over the top they go. Not a fun ankle sprain. So, even though it says Westfield High School, well, I don't know where you. All right. So that's why that now that we know how they occur, when we look at this, all right, step one, what's pre-wrap for? See if I can get it to stop and start. All right, what's the pre-wrap for? Yeah, just to protect the skin. Back in the old days, they didn't have pre-wrap. You taped everything to skin. That's the reason we tape to the top, though. It's because if it's like pre-wrap, if that's the tape and it's supposed to hold here, pre-wrap gets a little bit like, if you're a little loose, if it's a little moist, it'll start sliding because it's not grabbing skin. Also, to protect an inversion ankle sprain, we go inside out. And that's why we also do the heel locks that pull to the outside first, and then we come back to the inside. Now, can you think of any time that you would do that opposite? Huh? How about if they have a deltoid sprain? If the inside ligament is sprained, do I really want to pull everything out and then lock it in? I want to really get it just a little bit in inversion and then work really hard to try and keep it locked to where we don't get any more inversion. Okay, you guys know how to do that. Make sure that you get with Miss Bates on making sure you're proficient in your skills. All right, ankle fracture. Ankle fractures. Holy smokes, aren't they fun? In most cases, a fracture, you're going to see swelling and pain, and that's going to be immediately and extreme. All right, there may be no deformity, but a fracture is suspected, and you've got to know how to splint it. Do you know how to use our splints? No, that's different. Does anybody not know how to use the splints in the splint bag? Okay, I want to make sure that, yeah, suck the air out, and then we check capillary refill and check pulses. All right, so if fracture is suspected, you got to splint it, and then rise to control your hemorrhage. So get some ice on there, get some x-rays, get them to the physician. There are times that you would rather your athlete to have a fracture than a high ankle sprain even. Because when we talk, I don't know if we talk about this, but a high ankle sprain is where the tibia and the fibula get separated. And so that's not a fun thing. So there you go. There's a tib-fib fracture. Yep. All right. So here I am. I'm working a ball game, and it was soccer. And now I know you guys think that you never will ever use Pythagorean theorem, right? You'll never use it. Well, I'm glad that you know this, but I used it to figure out how far this guy was because I knew how far in on the field he was, and I knew how far away from me down the field he was. So I knew this one and that one, but I didn't know this third one. It ended up being about 60 yards. So he's about 60 yards from me. He's playing goalie, and he comes out. Here comes the ball. Here comes a guy from the other team, and he's instead of going to grab it with his hands, he goes to kick at the ball at the exact same time the other guy does. You can see this happening, can't you? And so he kicks, and they hit him right here. And I'm 60 yards away, and I hear it was that loud. All right? The adrenaline took over for him. He tried to stand up, and he had broken his tibia and fibula. So I got out there and I look at him. I check his pulse. He's got a pulse. Okay, I'm not going to try and reduce this and get it pulled straight. We're just going to put a splint on it and let's get him to the hospital. Right? Yeah, he had a tib-fib fracture. It's probably one of the most exciting injuries I've seen. But that's been a long time ago. I hope. And I watched us play soccer the other night, and we were playing against Waller, and our guys were really aggressive, and their guys were really aggressive. And I just go, oh my goodness, come on! I don't need to see another one of those. And thank goodness, knock on wood, we didn't. So your Achilles tendon. Who knows where your Achilles tendon is? Yes, it's that tendon right there. Now, anytime anytime that somebody wants to misbehave and be a horse's tail on a taping table, right? Or if you need to get the attention of your husband or wife, if you ever get right behind that part, there's the tendon itself, and squeeze right there. I didn't squeeze. If you squeeze right there, you will have their attention directly, and whole attention will be right upon you. Now, you might be called a few things you should never be called, but you will have earned their attention. So, now that you know the pressure point for there, all right, Achilles tendon strain, all right, can vary from severe to even more severe, being a partial or complete avulsion of the or rupturing of the tendon itself. The athlete feels acute pain and extreme weakness on plantar flexion. So, when do we use plantar flexion? Exactly. Every step has one and then the other plantar flex. And then it's followed by dorsiflexion. You plantar flex and dorsiflex all day long. So you'll see this when they're running, etc. Rice put a lift in their heel in the heel of their shoe and begin strengthening and stretching. Now we've already got it irritated. If we keep stretching it to where we feel pain, then we're causing problems. So your stretching has to always be when you feel it stretch, not when you feel it hurt. Putting a heel lift or one of those heel cups in their shoes, just by lifting their heel up a little bit, that's that much of a stretch that the Achilles does not have to do. Back in the day, my Spanish teacher, when I was in high school, she wore these shoes that were called candies. All right? Their heels like this all the time. The only thing that ever touched the ground was the balls of her feet every day. And then one day she came in and she started wearing sneakers. And I asked, I said, why are you wearing those? You wore those? I mean, like, you've always worn the other ones. And she said, my doctor has noticed that my Achilles is shortening because she was always up on her toes. And so to get up on your toes, you should shorten your Achilles. So that's the same thing as you're talking about with a heel cup. So tendonitis. Itis means something swollen. So you got an inflammatory condition that involves the Achilles tendon or the sheath around the tendon. And uphill running or heel workout can certainly cause this to start. You want to heel lift, ultrasound, ice, and treat symptomatically. Do you know what treating symptomatically is? According to how they feel. Exactly. So what is it called when it's the sheath around the tendon that's irritated and not the tendon? Teno, tenosynovitis. Tenosynovitis. Remember that word? All right. So which one of these does this athlete have Achilles tendonitis in? Left or right? I would say yes, certainly. We got time. Yes, we do. So here's this. Here's the person that's got the tendonite, the Achilles tendon rupture. They're running along, and boom, it's gone. Thompson test, their foot doesn't move. You got a positive Thompson test. Complains of a sudden snap that felt like somebody kicked them in their lower leg. It feels like somebody takes a stick and just goes whack on your Achilles. So pain is immediate, but it rapidly subsides. Toe raises are impossible because your Achilles tendon doesn't pull your calcaneus. Obvious indentation at the tendon site, and there's a positive Thompson test. This needs to go and see the orthopedic surgeon. You're going to have rice, Advil, non-weight bearing, put them in a boot, and they need to see the doctor. If they don't get this fixed within 2 weeks, the gastrocs will start to shrink, and they can't even, there's no, they can't put a winch on there and pull that down to get it attached again. So you need to get it fixed 10 to 14 days, just like with all tendons. What time are we at here? 40? Oh. All right, let's see what we got here. We got a bunch left? Yeah, we got a bunch left. All right, well, we'll talk about the peroneal tendon because we've got to go back and remind you where the peroneal tendon is. Okay? What is it, Joseph?